Thank you very much for this kind introduction, and thanks to Dr. Banshi and Dr. Shaukot for inviting me again to come to India. It's one of my favorite places in the world. It's a very exciting country to visit. Now I'm going to talk about preventing ketones and ketoacidosis in pediatric diabetes. I often begin with this picture of Robert, who was 13 years old when he drew it to me, showing the balance between food and insulin. And he also put a shark in the picture. And when I ask him, what is the shark doing there? He says, that's how I feel when I fall off the balance. And that tells me a lot because I don't have diabetes. My children don't have diabetes. But he's sharing his emotional burden of diabetes with me. Now, ketoacidosis is an imbalance of hormones. As you know, we have 4 hormones, adrenaline, glucagon, growth hormone, cortisol, that increase the blood glucose. But there's only one player on the other side, insulin, that lowers blood glucose. And ketoacidosis is an imbalance between these hormones that usually arises when we have a deficiency of insulin. And of course, the most simple explanation is that there is no access to insulin, which is the case in a newly onset diabetes. But it could also be a person with diabetes who has illness and thereby increased requirements for insulin. Insulin emission happens in mostly teenagers. Some teenagers do this to lose weight, and others do it perhaps because they don't really know better that they need to take the insulin. And if you're on a more sophisticated pump treatment, problems with the pump or the insulin delivery can cause ketoacidosis. So when you think about this, if you have diabetes already, you are trained how to take care of your body when you're healthy, which means you need food, and then you take insulin to the food. And you adjust the dose according to the carbohydrate content in the food. And most families learn that quite well. The problem is that when you're sick, you actually have to do it the other way around, and you have to start with the requirements of insulin in your body. And then, you have to take food and drink to the insulin, because otherwise your blood glucose is going to be too low. So you have to eat and drink to give the insulin some sugar to work with. For example, sweet drinks in small sips. And this is a problem for healthcare professionals as well, because often they don't realize that diabetes is not really a disease with an excess of sugar. It's a disease with a deficit of insulin. And unless you realize that, you're only going to treat blood glucose, and you can end up with a fairly nice glucose level, but you can still be in ketoacidosis, and that's really a problem. Now, this is in Swedish, so you cannot understand it, but it actually tells us about a 13-year-old girl who died because the family got the incorrect advice. So her grandparents were taking care of the child while the parents were traveling. And they called the healthcare facilities and asked for advice, and they said, oh, your child is vomiting, so she doesn't eat so much, then you must lower the dose of insulin. And she was vomiting because of ketoacidosis, and the lowering of the insulin even further caused her to die. So this is a problem even in a very modern setting like Sweden, where this is not supposed to happen. And of course it can happen in a place like India, but also other parts of the world. So if you're sick with fever, the child usually eats less, but the fever requires more insulin because of the counter-regulatory hormones. So one good way of starting is to begin taking the same doses as usual. And with fever, we know that doses increase between 25 and 50%. Those are only crude numbers, but they really tell us that the doses can go up quite a lot. So the advice here is to monitor blood glucose before and 2 hours after each meal. And then you need to check ketones as a sign of insulin deficiency. So if you have access only to urine ketones, that's what you're going to check. But if you have access to blood ketones, that's much more accurate, and I'll come back to that later. And you should always check ketones if you're vomiting or nauseous, because that's the most common clinical sign of ketones. And this is difficult because people think that maybe the vomiting is caused by the infection and not by lack of insulin. In this situation, we prefer to calculate doses in relation to the body weight, because somebody in remission might be having a low insulin dose, and when they're ill, they can very quickly go up to 1 unit per kilo per day or even more. So whenever there's vomiting or nausing in a child with diabetes, we must almost always think about a lack of insulin as the cause. And check blood glucose. If that's high, you check for ketones in the blood or urine, and then you'll find out that is also high, and then you know it's caused by the state of insulin deficiency. So we say it this way: when a child with diabetes vomits, it should always be considered a sign of insulin deficiency until the opposite is proven. And vomiting from gastroenteritis should only be considered when a lack of insulin has been excluded. So if there is gastroenteritis, you treat it very much in the same way as with children not having diabetes. That is, you give small sips containing sugar, and then you have to kind of turn it backwards for the family with diabetes, because otherwise we teach them to use light drinks and not sugary drinks together with the meals. And in this situation, you should not use light because it doesn't contain any sugar. And just as with any child with gastroenteritis, you give frequent small sips, and thereby you can avoid the vomiting. So sweet ice cream and yogurt may also work well, but never miss the chance to give something containing sugar. An extra excess of sugar in this situation does not do anything bad. You can always give a little bit of extra insulin. So if the child wants to drink water, you should try to have them to drink lemonade or juice or something like that instead. And then you keep records of how much the child has had to drink, and as soon as possible you begin with solid foods again, and that's when the child stops vomiting. And then you need to check the ketones, because ketones tell us that there is an intracellular starvation. The glucose will not go into the cells, and of course if there's not enough substrate, you will also end up with ketones. And we call those starvation ketones when the blood glucose is low and you have ketones. And in that case, especially if you have decreased the basal insulin, you need to give more sugar first, and then you can give more insulin. If it doesn't work, you can actually use the liver stores of glycogen by using mini doses of glucagon here. And the dose is, if you use an insulin syringe that's graded in 100 units here, U100, you can use 1 unit per year up to 15 units, and that would be 0.15 milligrams, which is a much lower dose than that we use for severe hypoglycemia, and it can be repeated. With high blood glucose and ketones, if you find out that the blood glucose is repeatedly above 15 millimolars or 270 milligrams per deciliter and you have ketones, there is a risk of developing ketoacidosis. And then a safe standard dose of treating is 0.1 units per kilo, given with a pen or syringe. And if you have access to rapid-acting insulin, that gives a quicker effect, but it also works well with regular insulin. We tell them not to give more at one time, because then you risk overcorrection and you can risk hypoglycemia. Then you check blood glucose and ketones, and if the blood glucose is not decreasing or if the ketones are not going down, you can repeat the dose. And we say with analogs after 2 hours, and with regular insulin, repeat after 3 hours. If you can use blood ketones, it's important to remember that if you check them after 1 hour, they often go up. But after 2 hours, they are very much lower. So you can immediately see that you have had a good effect of the insulin, while urine ketones stay elevated for many hours. So if we look a bit into the physiology, fat is broken down into fatty acids, and that will be fatty acid coenzyme A in the liver mitochondrion, and the reaction to ketone bodies is driven by starvation, low insulin, or a high-fat diet. And in this situation, there are usually no ketones in the urine. There is a little bit of acetone produced, and then the third ketone body is beta-hydroxybutyrate. And this is a kind of spare fuel for the body, so it can be used for the heart, for example, because the heart has an insulin-dependent uptake of glucose, but the heart can use ketone as an alternate fuel, as well as the kidneys, muscles, and the brain. So if there's a deficit of insulin, the low insulin is going to drive for a production of ketone bodies. Acetoacetate, that will be excreted into the urine. Acetone, that gives the fruity breath, the Kussmaul breathing, and then beta-hydroxybutyrate. And in this situation, you will get much more of beta-hydroxybutyrate. So usually there is a balance 1-to-1, but it can go up to 10-to-1 in this situation. And sometimes there is not very much acetoacetate produced. So then the urine ketones will be low, while the blood ketones will be high. And that's the only way to find the ketones then. Now, after you give insulin, you will block this conversion here because of a high insulin level. But some of the beta-hydroxybutyrate actually converts backwards to acetoacetate, and it's going to continue to be excreted in the urine for many, many hours. And acetone deposited in the fat tissue will reappear as well. So in this study, they looked at the difference between blood ketones and urine ketones. Here we have the blood ketones on this level here, and here we have the urine ketones. And you would expect them to be very similar, which is these numbers here. But actually here you have a couple of patients, 15 patients with a normal urine ketone, and one even had a level of above 3 in the blood ketones, which is impending ketoacidosis. So these patients are at risk for ketoacidosis without being known because of the negative urine ketones. And here are patients that still have a high level of urine ketones, although the blood ketones are negative, showing that there is no deficit of insulin anymore, and you risk over-treatment. And there are a number of devices today that can actually measure blood ketones. The problem is, of course, that that is more expensive than a blood glucose test, but if you compare instead with an admission for ketoacidosis, it is, of course, much, much cheaper. In this study, they measured blood ketones and found that they had 60% fewer hospitalizations and 40% fewer emergency assessments in the group that did measure blood ketones. And again, which patients did measure ketones? Well, when they were sick, actually only 60% measured in that group measured urine ketones, while 90% measured blood ketones. And for teenagers, that rather take 10 blood tests than 1 urine test. But for a dehydrated toddler, of course, it's impossible to produce urine on command, but you can always get a blood ketone test. Now, here is an example of when you have an insulin pump, and then you have a very low insulin depot because you're continuously infusing regular or rapid-acting insulin, and there is no long-acting insulin. So in this situation, when the needle came loose, the blood glucose is going up, and here the boy checked and found out that he had ketones. He took 0.1 unit with a pen, new infusion needle, and then the glucose came down nicely. And here we have an example of pump problems with ketoacidosis, with a slightly lowered pH, high glucose reading, blood ketones 3.6 and 3+ in the urine. Now, 2 hours later, the ketones have gone down a little bit. pH has gone up a little bit, still very high glucose. But 4 hours after admission, the blood ketones are normalized, while there are still very high urine ketones. And the glucose is still elevated. But here you know that you have really cured the ketoacidotic state. And blood ketones are a very good method of following in the course of ketoacidosis treatment as well, because then you can see that they go down, and you know you've given enough insulin for the treatment. Now, if you're using a pump, it's important to remember that the ketoacidosis or acidosis is never a fault of the pump. The ketones appear when there's a stop in the insulin delivery, and every pump patient should know how to handle that and how to go on to syringes or pens instead. What happens if you stop the pump? Well, we did this on an outpatient basis, and then in those that didn't have any endogenous insulin production, you can see that there's a sharp rise of blood ketones rather quickly. So the pump was stopped for between 6 and 8 hours, but we didn't have anyone with a pH below 7.35. Lowest base excess was -5, and less than half actually had nausea. So that means that the pump patient can do without insulin for 6 to 8 hours. And the rise in ketones is about 0.2 millimolars per hour here in these patients. Those that did have some endogenous insulin production rose much slower. But it's important to remember that alcohol in teenagers actually can cause ketoacidosis overnight. And in young kids that are sick, of course, the ketones will develop much quicker. So some advice how to keep out of ketoacidosis when you use the pump. Of course, you begin by taking extra insulin when you have a high reading. If the blood glucose doesn't go down, you should check for ketones. And if you have elevated ketones, it's very important to take the extra dose of insulin, but with a pen or syringe. Don't use the pump in that situation, because there might be something wrong with the insulin delivery. Now, in the morning, if the blood glucose is high, you should check immediately, because you don't know if there's been something wrong with the insulin delivery during the night. And if the child is going away for school, for example, you want to be able to treat them before they go off for school. And in the evening, when you go to bed, you want to check, of course, the same situation. So check for ketones. And if you're not feeling well, you should always check for ketones in a pump patient. Then you change the infusion set. And if you do this correctly, 99% of the ketoacidosis episodes in pump patients can be prevented. So it's important to remember that the best friend of the pump is actually a pen or a syringe, which you must always carry with you when you travel. Now, for recurrent DKA, often psychological factors are present. And there is often insulin emission, which is an attempt to lose weight in some adolescents, or to escape intolerable or abusive home situations, or depression. So in that situation, a psychiatric, social worker, or clinical psychologist should be consulted, and adult supervision of insulin administration can be helpful. Insulin emission, like I mentioned, is often the case for a recurrent DKA and not taking insulin with a pen or a syringe. If the patients and the families know what to do, the infection should not cause ketoacidosis. And if you look at the ketoacidosis at onset, countries like Sweden, where diabetes is more common, has less ketoacidosis at onset, only 16%, while you see some other countries with a very high frequency of ketoacidosis at onset, but lower incidence of diabetes. So in Italy, it was a bit disturbing with a high risk of ketoacidosis at onset, so they put on posters for 6 years here, just about everywhere where they were exposed to children, and they could reduce the frequency from 78 to 0% in the school age group, which was very well done. So ISPAD organized a similar campaign in collaboration with IDF in 2008, and you can find the posters at our homepage, and you can also translate them to your local languages. But of course, it's very important that this needs to be repeated. So thank you for your attention. I'd like to acknowledge my diabetes team here, and also thank you for the friendliness we've met while traveling in India. And I'd like to invite you all to come and visit us in Brisbane, where we have our next meeting together with APIC. Thank you very much.